Welcome to the Senior Rehab Podcast.
The podcast for rehab clinicians that want to better serve older adults.
And now, your host, Dustin Jones.
Hello, friends. Welcome to the Senior Rehab Podcast. Thank you for the download. Today, we continue our conversation with Cindy Kraft. This is part 2 of our conversation where we dive into providing value beyond the visit. Once again, Cindy Kraft is a physical therapist, former home healthcare section president of the APTA and president of Cornetti and Kraft Healthcare Solutions. She has an abundant amount of wisdom and advice for people like you and me. So if you haven't listened to part 1, go ahead and do that and then check back in with this episode with part 2. Without further ado, let's get back into this with Cindy Kraft, physical therapist. That's helpful. So let's see. I want to know from your end, what are you excited about in home health in terms of the future of our little niche in physical therapy? I shouldn't say little, it's pretty big. But what are you excited about?
I am excited about bundled payment. And I know that sounds bizarre.
All right.
We're not excited about bundled payment.
Yeah.
It's kind of a, feeding frenzy. The hospital's going to leave us out. And it's all going to be, and I think after a while in any setting, is any news that comes down ever going to be seen as good? I mean, we will agree that the current model is broken. Yeah. That being paid by minutes or visits or CPT codes really has not done well for therapy. Yeah. It's created the idea that wherever you put the dollar, that's how much therapy people are going to get. I mean, recent reports coming out of the skilled nursing facility of the ultra high use and the just into those categories. I mean, you look at that in home health with the visit moving around and stuff, you realize that it has to be something different. And so when you look at a bundle, CJR definitely being the top discussion right now because of its mandatory status this week.
Could you tell us what CJR is for anyone
the
not familiar?
comprehensive joint replacement.
Okay.
It affects about 800 hospitals. This is a mandatory bundle in which the pricing is looked at from the hospitalization to 90 days post. So it would affect the use of home health, skilled nursing facility, outpatient, whether it's the hospital's outpatient or a freestanding outpatient. All of that is being looked at from a cost perspective and how to lower the cost overall. But when you look at that, there's been a lot of regulation specifically to CJR, and you get reading some of the bundled stuff and it makes your eyes go crossed. But there was a word that jumped out to me in CJR specifically, where it talks about care redesign. And not only is it a suggestion in the rule, it is mandatory that participating entities show evidence of care redesign, which means they're not looking for you to take the way the hospital's always managed the knee and the way we've always managed the knee and just stick them together. Yeah. They want to see collaborative effort. And so to me, care redesign is a huge opportunity for us to, kind of get the juices flowing again about why are we doing what we're doing? Especially the question I love to ask home health therapists is, can we do daily therapy in home care? Overwhelmingly, the response remains no. And the issue is, I love when it becomes a rule. Yeah. Well, if you need daily therapy, you're supposed to be in a skilled nursing facility. Yeah. No, let's just treat this like an AA meeting. And let's just be honest, because this is more about staffing than it is about patient need.
Really?
I mean...
and not about payment.
No, because if you look at it, the number of therapy visits still affects it. So front-loading this for certain patient populations makes sense clinically, and the financial side will work itself out. But how do you justify someone coming home with a fresh knee and you writing it for twice a week? Yeah. This doesn't make sense. And really, so the care redesign piece in the middle of all the rule about who's responsible for what part of the payment and all this other stuff really just struck me as, man, so Medicare wants to see us do care different. So let's do it different. I mean, really, because I think it's a huge opportunity in a bundled payment. And I think the risk for home health is we kind of sit on our laurels a bit and say, well, if you look at us compared to the rest of them, we're cheapest. I mean, we are. We're cheaper than hospital stay. We're 60 days of being managed is way cheaper than it would be at a skilled nursing facility, inpatient rehab or anything. So, but the thing is, cheapest doesn't necessarily mean we're the best, because many of these bundles are tying it to say you might meet the financial targets, but if you don't meet the quality indicators, you still don't get your bonus payment.
Yeah.
So our ability to get in on these and really look at the quality of care we provide and how are we really managing this. I think our role in reducing rehospitalization, which we know is a huge measure for home health, has got to be beyond just falls.
Yeah.
Because I say this all the time, Dustin, I don't even know why people call them fall prevention programs, because you fall first and then get in one. I mean, really? You name it fall prevention, but like 99% of these people fell and then you ordered rehab. So that's not fall prevention. So really, I think the care redesign is really got me excited about, can we get out of our own way? Well, that's not how okay, then we do it different. And I think for home health therapists, we love that continuity with the patient. I absolutely agree. But sometimes that's going to mean that you and I look at our schedules and say, Mr. Smith here needs to be seen daily. I can fit him in Monday, Wednesday. You can get him Tuesday, Thursday when you're in this same area. And we're going to tag team him.
Yeah.
But there's a fear factor there. There's a my patient, my thing. And I think with some of that sharing, we will see more of that conversation about clinical practice.
Yeah.
Not that you're going to go check up on each other, but I'm sure you've had this happen where you go to make a visit and you go do what you would normally do. And the patient goes, well, no one's had me do that.
Right.
No one asked me to do that. Yeah. Especially you bust out your kettlebell. Oh my God. You're going to it looks like some medieval torture device.
I know. Is that a cannonball?
You're going to hit me with it? What is that? But I think that's going to help us. So that care redesign is a word that since I saw it, it just has really sparked we could have some seriously good conversations in home health about how do we do this different and how do we approach that collaboration. We're not saying, how do we make a program that steals them from the SNF? Because there's patients we both know that need to be in a skilled nursing facility.
Right.
But how do we decide that now? How do we determine what that system will be? So I see huge potential, but I see a lot of anxiety, fear, and I'll wait until it's mandatory.
Yeah.
And that concerns me because that could be very much too late.
Yeah. Do you feel like we have the ability to improve the collaboration amongst those different players in terms of, just all the different people that interact with the patient that are kind of in this bundled payment system? Because that's one thing I see as being a challenge in terms of being able to communicate easily and consistently with all, whether it's a surgeon or the PT in the hospital or nursing staff or whatnot. What do you think about that in terms of teamwork?
Well, you don't like those orders that just say eval and treat and don't even give you a weight bearing status.
I'm coming to expect those now. I'm surprised if someone actually gives me information.
Well, I love the PT admit for the UTI.
Yeah.
It's like, are you sure? Yeah, it's a PT admit for a UTI. Get out there, blind in one eye, legs gone, old stroke. I see how you missed all of that in light of the UTI that resolved 3 weeks ago, but thank you. That's good information. I think part of it, the bundle, and unfortunately, it does take mandatory or fear sometimes to make people reevaluate how they're doing this. I think part of the problem has been that within the rehab community, we're approaching this as competitors and not collaborators. Maybe not so much on the acute side. It feels more to me on the post-acute side of send them to us instead of outpatient or go to outpatient instead of SNF, as opposed to saying, you know what, the three of us offer 3 different venues for this based on the needs of the patient. And I'm not trying to take away outpatient business. I'm just telling you that those patients that you see asleep in your lobby that miss visits, who don't necessarily participate very well in outpatient, very well could have used a short course of home health to get a lot of those other issues taken care of so that they're able to participate and benefit at your level of care. And that's where I think the conversation is not about who's cheaper or who moves who faster, but to really say, how do we, as the post-acute setting, really work to set those standards of these are the types of patients that should go to home health. And if just because, especially with joints, just because they came to home health doesn't mean now they're not going to go to outpatient. I mean, but it's a timing issue. We've probably all had the patient who maxed out their days in the skilled nursing facility. You get him and go, what did you do?
Right.
Then they start, batting around a balloon and squeezing, their hands. And it's like, oh, okay, whatever.
Yeah.
But I do think it's going to require, and bundles are going to force the hand a bit, but I think it's got to be home health acknowledging, especially on the rehab side. We're not here trying to pilfer your patients.
Yeah.
And it's not, for some reason, it seems to be an either or, especially in the minds of many of the outpatient therapists I've met, that the patient, when they're discharged from the hospital, goes to home health or outpatient, not the connection between the two.
Yeah.
And so I think that, and the acute care side, boy, that's a tough one. I've talked to acute therapists and said, one thing you could do for me, could you just develop use of the term independent in this setting?
Yeah.
Because when you slap independent on this, it's because you had, wide hallways and well lit. The dog was not there.
Yeah.
Okay, so that right there took care of all this stuff.
Or the cockroaches and rats, right?
Right. But, I think even, that particular issue with pets is one of our most common war stories. And in talking with clinicians, they're very clear that they'll put, the percentage of home health patients with a pet at 80% or higher. Yeah. And I'll say, so why don't I ever see it in the documentation? Why would you not make that part of a goal statement? Why would you not tie that to a balance or safety issue or cognitive issue? There's umpteen thousand functional things in relation to that are not ever going to be touched in any other part of the continuum. We're the only one who sees the dog in the little sweater.
Right.
Sitting next, the big ones are like, at least I know where they are. It's
right.
Ones that look like, oh yeah, go ahead, grab her leg, see what happens. But I think that's the collaborative piece that education component. And sometimes I know it makes people roll their eyes at me like, it's some sort of, we're all just going to group hug and sing Kumbaya.
Yeah.
But I think that things like bundles force the situation.
Right.
What scares me in these mandatory CJR situations, though, is that many home health agencies, either by their own volition or they show up at the meeting to discuss a bundle, and it's really just a version of how few visits can you do this in. And I understand that could make us a perceived cost saver, but I advocate to therapists desperately right now that if you agree at this point in time that total knee or that total hip could be managed in 4 therapy visits and in 4 therapy visits only, you understand you will be setting the tone for all total joint replacements in home health going forward.
Right.
Because if that becomes the norm in a mandatory bundle situation, then that's going to become the norm for everybody.
Yeah.
And then we're going to yell and scream about how they're complicated and they have this other thing and they have to manage the pets and they have the other. And I think we have to really look at this and say, what are we trying to accomplish with our patients? So it's that care redesign piece. I don't see enough conversation. I see a lot of doom and gloom about the bundle and, we're going to get paid and is that going to work? Yeah, there's going to be things to work out, but I think care redesign is a huge opportunity for rehab to say, I do more than walk people to mailboxes. I do.
Yeah, that's a good point. All right, let's transition into some quick questions. Your responses don't necessarily have to be quick, but I wanted to start off with some listener questions. Bud Langham, you're probably familiar with him. He asked, how big of a threat is prior authorization?
I think a lot of the anxiety about prior authorization comes from our efforts when we have to deal with that with any payer. I think one of the risks is delaying the ability to start therapy.
Yeah.
It's an issue of, it sounds great on paper to be able to, contact this and get your authorization. But you and I both know that can get ugly quick in terms of the amount of time. And now, especially if you're talking about a higher acuity individual coming out of the hospital or post-SNF and having to sit for a period of time waiting on the auth.
Right.
I think we could, from a functional perspective in particular, see patients decline in the amount of time it's going to take to get this. Or, you put the rest of the services into it. You're really going to make them wait for that nurse? How long are you going to make them wait?
Right.
I think the other piece is the anxiety around what happens if they say no. I mean,
Yeah.
I go do my evaluation,
Yeah.
and we know that there's always, I hope to live long enough where I don't have to hear about therapy patients, hips, knees, and strokes. Yeah, we'll probably be able to get decent turnaround time on and off there. But when you start talking about, here's my care plan recommendation for someone who's 102 with CHF, which could be a very viable maintenance program, well thought out, well planned out.
Yeah.
Am I going to get a no because I'm dealing with somebody who goes, that's not a rehab candidate? And I know, the whole post GMO, and they can't really say that, based on improvement. But man, that message has not necessarily gotten to all our intermediaries at this point, let alone if I'm hinging on them understanding that well enough to approve my program from the beginning.
Yeah, that's a good point. Our friend D asked a couple questions as well. Why do you find so much joy in auditing therapy documentation?
Well, I think it's one of those where at times you have to laugh so you don't cry. I think in reading them, what I notice a lot of is when we work in our own individual institution, things kind of develop and everybody we're all kind of used to this. Sometimes I call it a shared delusion. It's all great. We haven't been audited in like 10 years. That means we're amazing. It's like, no, that could mean you got problems you just don't know about.
Yeah.
By being able to step outside of a single agency and looking at the documentation issues, the examples you find that make people chuckle, that make people look horrified. I like the fact that I can say they come out of real charts. Not because I'm glad I found them, but they can be they can drive a point home quicker than 10 slides about why you should document better.
Right.
When you read some of this and go, that's embarrassing.
Yeah.
One of my favorite nursing examples, because I do read nursing documentation too, and they'll complain. Well, you're not a nurse. Well, no, but I can read. And that wound changed sides of the body 3 times in the cert period, as did their gender. And it was temporarily a diabetic wound and then went back to being a stasis ulcer. And yeah, I don't know what you thought you were putting in there. But, you look at that and say, we have to own this piece. We do. It is a testament to your skill. And so, there's days I'm reading, I'm going, if I got to read one more. And this is why I have a great empathy for people that review other people's documentation in an organization. I always tell them, first of all, let me be the first to tell you out loud, nobody likes you. We like you as a human, but we're thankful for caller ID. Let's put it that way. And that's why they put you in a cubicle toward the back.
Yes.
So the clinician doesn't kill you. And more importantly, you don't come out and kill the clinician.
Right.
Because it's like, if you write the same dumb thing in here for the 10th note in a row, I'm just going to have to injure you. We'll figure out, I'll call Dee and ask her what, the ICD-10 code is for bludgeoning, because I can't believe you do this. So what I've seen though, is when you hold a mirror up to the majority of therapists, they look very shocked that that's how it was coming across in the documentation. And I have seen time and time again, the majority go, oh my gosh, that's not what I meant, and change behavior. There's always going to be a couple that, whatever. But I think a lot of therapists, it's that apathy and not seeing something different and not having somebody, although it is painful, hold up a mirror and say, so why do you do that?
Yeah. Painful, but so helpful.
But again, like I said, the majority of therapists, when they see that, they change it.
Yeah.
And they say, but I always tell them, I'm not sending you a new list of what words to use. I'm saying, is that what you want to say about your patient care? Well, no. Well, then don't.
Yeah.
I mean, don't do this, because this is what it really looks like. So I feel it's, kind of developing care plans that may not be the patient now, but they're care plans for clinicians to say, I know you do a lot of good things. Yeah. Let's stop making it look like the neighbor kid could have come and done the same visit.
Right. Very good point.
And it gives me plenty of fodder, all HIPAA protected, but to take those little snippets of documentation and text them back and forth and poke the bear periodically about, guess what I found today?
Yeah. You should start tweeting some of those out as well. I'm sure some people appreciate that.
I can sense the implosion in Central Florida when she reads a couple.
Yes. So her second question, this is D again. Why the obsession with ankle pumps?
Oh, well, my issue is, when did that become the go-to PT program? that
Mhm.
I understand that, as you do, that when you develop exercise programs for the home health patient, we're on their turf, and we
Yeah.
have lost the leverage that therapists have in inpatient care and in outpatient facilities. That the patient will overwhelmingly do what you ask because they want to get away from you.
Yeah.
They want to go home. They don't want to come into the clinic
Right.
anymore. So they'll do all kinds of stuff. I mean, I'm sure you've had your experience where you're looking at this sweet little elderly person and say, wait a minute, you supposedly were doing 3 hours of therapy a day last week at the SNF.
Right.
Now
Right.
you told me if I try to come more than twice, you're going to die.
Yeah.
So,
Come
so
on
now I'm trying to put a program in here, but I got to kind of find that balance and buy-in.
Yeah.
And so I understand the bringing in a few exercises sometimes is trying to build trust. I love taking students into home health when they bring out a 29-page home program on the second visit. I'm like, yeah, good luck with that.
Yeah.
Wait till you see it. When you come back, there'll be coffee rings on
Right.
it. But so I can understand some of those kind of trust building things, but you look at it and say, my goodness. I mean, I go into charts and I find ankle pumps. There they are on amputees. There's no leg, but ankle pumps are still in the program. The one that nearly did me in of late, though, was a PT admit, and they did not update any of the diagnoses in this assessment to reflect the primary need for home health. And so here are ankle pumps front and center on the home program, and the primary diagnosis of record is acute vaginitis. I was unaware that these have become so magical that they fix other things as well. I realized the connection here. So I look at this, and to me, the ankle pump in my mind has come to represent the apathetic home program.
Yeah.
It is, here it is. And even if, again, it's just to get them started, or we're talking about the circulatory benefits into week 2, into week 4, it's still there.
Yeah. Yeah.
No resistance applied. Just keep pumping your ankles. And it's pumping. Like,
in with the good, out with the bad.
Right. And it's like, and then, 2 sets of, are you kidding me? What is this doing? This doesn't do anything.
Right.
And I guess that's for me where the ankle pump has just become the epitome of, have you given up? I mean, is this really all you think that needs to be in there? And at what point, I think, especially with our exercise programs, is even if you're starting small, at what point do those need to either be changed or removed out of your program?
Right. Right.
I mean, I don't want to see Dustin number 1's ankle pumps. I mean, it's kind of like, can you stop those? No, I don't think they're doing anything.
That's a good point.
So yeah, that is, especially you find it on the amputees. It's like, wow, we've just got, and then I love when it's like, well, but it was a mistake. Well, that just means you're not even looking at what you put here. Because why would you put that in there when they have no leg to do this with?
Yeah. We didn't talk much about this in terms of your term as the president of the home health section, but what was the hardest thing about being the president of that section?
I think the hardest part for me was to try to balance clinical passion and development of that kind of content and the absolute necessity around regulatory and documentation issues. And I think people can get extremely passionate clinically, which I commend them for, but then that becomes the be all and end all of the conversation. And it's like, but you have to understand that we may be advocating specifically for physical therapy for these specific things in a specific patient population. I understand that. But if you look at the landscape, post-acute care is being all lumped together. And so us kind of making it one little piece of the conversation is kind of missing the larger landscape that is not talking about physical therapy and dry needling. It's talking about post-acute continuum. And so I think that's the piece where at times I felt, how do we keep that other piece in this conversation? Because, we need to be, we're the home health section of the American Physical Therapy Association. That is a very specific group of people working in one setting. But my other issue is, where do the SNF people land? Where does inpatient rehab land? I mean, this is a section for home health, but it's really becoming a post-acute conversation out there, not siloed. And so I think the challenge has always been to maintain the clinical passion that needs to be there. And we've said several times, to re-energize the therapist doing the visits. But I think the challenge of the regulatory piece, and at times, trying to be, I've teased Dee about this, in that, to take that mantle off after 12 years where I can have an opinion that is not got to be vetted past the opinion of the home health section of the Physical Therapy Association. I'm like, I did it for so long, I kind of forgot that I'd be asked something, and it was always that mental checklist of, wait a minute, your response can be seen as. You have to, because you shoot from the hip on some stuff, and all of a sudden it's, the home health section's position on X is, no. That's not. So I learned quickly to do that. And I think in about the 6 weeks I've been out of that, it's been kind of a relief to not have it always be. Yeah. Because I took that role extremely seriously about trying to represent the home health physical therapist and physical therapy assistant. And it's been a transition to move on and let that grow in the direction it needs to go next.
Yeah. Your work was appreciated. I'll tell you that for sure. So last question here. Let's say you are at CSM and you are in front of a room full of either students or new grads, PTs, PTAs, and you have their attention for 30 seconds to a minute. What would you tell them?
I would say, first, don't discount this setting. Don't assume that this is something that's 10 years out. We had someone come to the booth at Combined Sections who had been told that you can't do home health. Well, first of all, they were told you can't do home health unless you're a section member, which I was like, yeah, no, that's not true. But we should be. Yeah. I can't do it now. And I think that for students and new grad, especially for students, I always advocate, look for the rotation, look for the clinical experience as a student. Yeah. I think the biggest mistake is to assume it's down the road, it's not for you, it's not possible, because the future of home and community-based services is where a lot of conversation is about being cost effective and extremely functional. And so I think, looking at those payment initiatives that really promote medical management and functional management, the new grad, the student, the quickest thing would be, please don't slam that door. Yeah. Without looking at it first. And don't believe I can't possibly do it, or it's just not in. I've seen people, and clearly, and this is past my 30 seconds, I know this, but
you're good.
My advice to students always is, and to new grads, is that home health, like many other settings, can be quite desperate for therapists, and will hire people just because you're alive and have a license. Yeah. And so if you're interested in this setting, please ask the right questions. And I actually, for the students that I talk to once a year, I made a whole kind of list of what those questions are, because you could get hired tomorrow.
Right.
It doesn't necessarily mean it's in your best interest.
Yes.
If you don't have that. But I have seen people who've done, maybe 12 weeks in a home health agency as a student and decided that that's what they want to continue, because now they have kind of their networking with the other therapists and all that, and they want to continue. I think that keeping your mind open to the possibility, but always be aware that you could end up being the only therapist in a location. And unless you have the skill set and or mentoring network to do that, you just need to be very cautious about it. So you don't want to slam the door, but you also don't want to throw it wide open, because you could end up in a very difficult situation as a new or recent grad without adequate support.
Yes. That is very, very good advice that I know many people will take to heart. And I know I definitely would have valued that coming out of school or even in school for sure. But yeah, so thank you, Cindy Krafft. You're awesome. Your work, just your perspective. I mean, just in this conversation, I've been challenged tremendously in how I treat my patients and how I document those treatments. So yeah, your work is appreciated in education and, with the section and your perspective is very valuable. So, if people want to pick your brain a little bit more, is there a preferred way that people could reach you?
Well, I prefer email only because we get so many. Cold calling people in home health is never good. They could be right up in a visit or driving, and you don't want to, kill people. So my email address is Kraft, Krafft.
Okay.
Yes, it has 2 F's. Please don't do what happens to me on nearly 90% of my hotel check-ins. Are you sure?
Right.
They ask me this. Are you sure? I'm like. So yes, it has 2 F's. It will not get through if you pick one. And then it's value beyond the visit. I know that's long, but it was very intentional.
Yes.
In relation to, we can't just be knocking out widgets. So value beyond the visit. I like that route, Dustin, because then we can set up a mutually agreeable time to talk.
Yes.
Or respond to a question, then kind of trying to blindly grab somebody on the fly. Right. So,
and Twitter,
because I think.
Sorry. Well, and Twitter as well, because you're starting to become more active on there.
I got to keep up with Dee.
I know, she's all over the place. My gosh, she's on there a good bit. But yeah, so your handle is at Cindy CINDY _Kraft with 2 F's.
Yes.
And sorry, I interrupted you. You were going to say something.
No, I don't remember.
That's okay.
No, but I very much appreciate your time and opportunity to do this as well. If there's other issues that come up down the road, I'd be happy to do it again. I think that, we have so much opportunity that I'm just very afraid of us getting to the game late. When you look at the MedPAC report, every year for the last several years, they say something about getting rid of the payment relationship between therapy visits and home health. Every year they complain about they don't like what it does and the visits and everything else. However, it struck me in the report, most recent one, is not only did it once again say it needs to end, it put an end date of 2018 on it.
Oh, wow.
And so I think we have, and again, people will say, well, that won't happen, or whatever. But I prefer to look at it and say, we got about a 2-year window, just under, to get our act together, that our value is more than the visit.
Yeah.
Because if we wait until then, my biggest fear with the removal of that is we will be cost. And look what's happened to nursing, whose visits don't correlate to reimbursement, that them and their daily wound changes or BID dressing changes that when I came into home health were like, woohoo, and give them a home health aide every day, have now gone down to, and a lot of it is good, better management. But I'm afraid for rehab, if we've just enjoyed our kind of preferred position, because if we do a certain number, it makes more money for the episode. If that's gone, and we have no other value other than what our bottom line contribution had been prior, we can see our use drastically changed. And I don't want to be the chicken little, the sky is falling. But too many indicators up to this point say, you take away the fact that my 7 visits add X to your bottom line, and now I want 7 visits that doesn't add to your bottom line. It could be very, especially when you're looking like in a lot of the stuff I've read and seen from you. I mean, a lot of those patient populations are not your hips, knees, and strokes.
Right.
How are we going to get those referrals if we don't show our value sooner, as opposed to, here, let me show you all this research and great stuff. I'll get out my kettlebell in 2018. It's going to be too late to bring that thing out in 2018. They're just going to say you're doing it because you got scared about the money, as opposed to, wait a minute, we have a care redesign. Own it now, and then when that day comes, there's going to be bumps with it. We know that, but we can't wait until there's an official date or an official this, and then try to change it, because I think we're going to have a problem justifying that this was about patient care as opposed to panicking about the dollar.
Yes, you heard it, people. Own it. Provide value beyond the visit. Don't wait till 2018. And
care redesign. That's my thing.
And care redesign. Yes.
I think it's a great word. I'm like, it's in the rules. It's mandatory for CJR participation. Yeah. So let's just run with that and redesign some care.
Yes. All right. Thank you, Cindy Krafft.
You're welcome.
Hit me. Thank you for listening to the Senior Rehab Podcast. The show notes for this episode and much, much more can be found at seniorrehabproject.com. If you found value in this conversation, please share this with one other person that could benefit. And until next time, do not forget to stay funky.